from Sunanda IVF and Christian Women's Hospital, Kolhapur, and today I am going to discuss with you IVF procedure for poor responder or IVF procedure for women who are suffering from low ovarian reserve. It is also called diminished ovarian reserve. It's also called low AMH, low antral follicle count. Various people, lay people will have different way of addressing the situation. But what I mean by low ovarian reserve is basically less number of eggs. The neighboring slide is showing you 3 ovaries. There's one ovary which is showing less than 3 eggs, and these are the women with least number of eggs present in their ovary. The second one is about 6 to 9 eggs, and that's about an average number of eggs which are commonly seen. You can say anything between 6 to 12. But when the number of eggs is beyond 15, especially beyond 20, then we call it a polycystic ovary, where a large number of eggs are there. Now, both these ones, the ones with a large number of eggs and ones with a less number of eggs, both are a bit of troublesome patients. Before we go to the IVF procedure proper, let me tell you what is the fate of the eggs. At birth, the girl is born with large number of eggs, and by the time of puberty, by the time she gets her menses, by that time a lot of eggs have vanished from the ovary by a process called apoptosis. Science really does not throw much light upon why the eggs spontaneously start decreasing. But once she achieves menarche, with every menstrual cycle, there is some few amount of eggs get recruited, maybe about 10 to 50 eggs will get recruited to develop, to become an ovulatory follicle. But only one of them will become an ovulatory follicle and liberate the egg to get fertilized, while the rest of the eggs again undergo 2 processes. One is apoptosis or atresia, and hence the number of eggs keeps on coming as the girl advances in age. So for all women, as they age, as this following graph is showing the mean and median of the number of eggs, and which keeps on decreasing as your age increases. So by the age of 40, very minuscule number of eggs will be remaining in the ovary. And this number of eggs estimation is done in 2 ways in my field. We in IVF practice, we will do a sonography to know what is called an antral follicle count. Generally, this sonography is done on day 2 or day 3 of the menses. We do a transvaginal sonography that literally tells us the number of eggs in each ovary. Also, we estimate by doing a blood test called AMH or serum AMH level or anti-Mullerian hormone level, and that also gives us a glimpse of the amount or the quantity of eggs which are remaining in that ovary. It is sad to know that Indian women, compared to their counterparts in the European countries and American subcontinent, and also to their counterparts in Vietnam and China, we tend to maintain a low ovarian reserve compared to all these women. We really don't know the exact reason. Is it the crops we eat? Is it because of the fertilizers which are there? Is it because of an environmental pollution? It is just our ethnicity. Being Indian means you have less number of eggs. There are various studies which are published in my science comparing the women from the Indian race and to that of the European race. And what we have found that Indian women have less number of eggs and really difficult to stimulate. And the average age of menopause in India is about 47.6 years compared to that in the UK, which is near about 51 years, and that in Japan is also high. So our Indian women normally have a less age of menopause, that's about 47. But again, a very large study which came from Bangalore, which said they scanned about 22,000 women, and they found out that surprisingly, 12% of the Indian women, they have menopause just by the age of 40. So it is so sad that these women, by the time they achieve age of 30, their number of eggs will keep coming down. And by 40, they will be menopausal. Don't you think in India, most of the women are planning a pregnancy beyond 28 years of her age? Because most of them are working women, they are chasing higher educational goals, they are career-oriented women, they want to work and get established socially and financially before they even plan pregnancy. So childbearing age, or desire to bear a child, has shifted from the yesteryears of 21 to 25 in India, which will be still prevailing in some rural communities in India. But semi-urban and urban communities, as the literacy level and education level of women is increasing, and more these women are planning pregnancy beyond the age of 28. And at this age, if you are planning a pregnancy, you must know whether your ovarian reserve is well. So, if there is any couple who wants to plan a pregnancy, the first test I advise in that couple is please try to know what is the ovarian reserve of the wife. If the wife's ovarian reserve is low, you better be fast in taking treatment. If the wife's ovarian reserve is normal, well, you can go with step-by-step maneuver. So, this comes to a very interesting question. I'm sure a lot of women today want to ask this question to the doctor. Can I delay my childbearing? Not only the women, the parents keep asking me. They ask me, well doctor, my daughter is getting married and she'll be doing her MBA, she'll be probably moving abroad for her courses. After the certificate, she's going to come back and then try an establishment. And well, she just wants to enjoy her married life for 1 or 2 years. Can she plan a pregnancy later? Well, then before taking these career choices, so before making a choice of delaying the childbearing, you must know certain facts about your ovarian reserve. I would definitely advise all these women who want to postpone their childbearing. Do you know your AMH value? Please get it done. It's a simple blood test. It will cost you about 1,000 to 2,000 bucks, varying upon depending on which lab you choose to, and it should be beyond 2.5 nanograms. Then you are reasonably okay. If you're beyond 4, thumbs up for you. Then you can delay your childbearing without any issues. Secondly, you do your FSH and LH levels also. They are generally done on day 2 or day 4 of the menses, and it should be less than, preferably 8, but at least less than 10. That also is one good indicator that your ovarian reserve is good and you can plan certain delays of childbearing are okay. I would go more by AMH and less by FSH and LH. But if the FSH and LH level is beyond 10, I will never postpone my childbearing. I would plan it as fast as possible. You should get a sonography done by a sonologist or a gynecologist to know what is the antral follicle count. If, as I showed in my first slide, if the number of eggs is beyond 10, well, you have a good number of eggs and you can definitely plan your pregnancy a little later. But if your number of eggs is less than 5 per ovary, well, you think twice. Think of pregnancy first. And obviously, this is just a general practice advice I would like to give. All women who want to chase a pregnancy must know their thyroid level, TSH level, and hemoglobin. Because a high TSH level is associated with abortions and preterm labor. So it's better to have a good TSH. Not only that, having a good TSH level ensures that your baby is neuro-intellectually normal. A pregnancy with a high TSH level, baby could be neuro-intellectually low. So IQ could be low. So you may have a very good IQ of your baby, you must have a good TSH level less than 4 or less than 3 will be best. And your hemoglobin level. All the complications of pregnancy we see, like abortions, preterm labor, or pregnancy not doing well, pregnancy having some birth defects. One of the major reasons is anemia. So you must be having, should be having a hemoglobin of beyond 10 grams to plan a pregnancy. So once you know all this thing, let's go ahead and understand our poor ovarian reserve better. So now I'm concentrating on the women who are having low ovarian reserve, which I've already told you. Women with low antral follicle count or low X, and women whose AMH level is low. Generally, low AMH level means less than 1.8. These are the women we start classifying that this could be having patient with diminished ovarian reserve. What we have found that as the age advances, this following graph in the slide is showing you your live birth rate starts slipping down. And let me ask this question in reverse way. I deliver about 50 women a month. How many of the women in the whole year are beyond 36 years of age and they come to me directly saying, well, doctor, I got a spontaneous pregnancy. In the whole year, I would have not more than 4 women like that. So most of the pregnancies are achieved less than age of 32 to 35. Few beyond 35, the chance of pregnancy drastically goes down. And second important point is, this could be related to the quality of the egg, not just the quantity. That as your age advances, your miscarriage rate, your abortion rate increases. So your fertility is coming down and your miscarriage rate is going up as your age advances. And you are in a very difficult situation where you want to achieve your pregnancy early, but the pregnancy rate is low and the miscarriage rate is high. And that's why I have made this video to tell you how to go ahead with a faster planning of this pregnancy. Obviously, all these women who are suffering with low ovarian reserve, I would advise them certain initial treatments. One of the initial treatments we give them is called DHEA, and commonly used a drug called anticonvulsant DHEA, which is available at 75 milligram in the market. I give about one tablet a day for a period of 4 months, not 1 month, 2 months, just 4 months. This DHEA was used as an anti-aging pill in the United States a few decades back. And they realized when they were using it as an anti-aging pill, some of those women got pregnant. So, there were scientists like Gleischer et al. And Kassan et al. And they published various scientific papers. And these scientific papers are telling us that the women who use DHEA have better egg number, they try to maintain their egg numbers better, they achieve even natural pregnancies, and the miscarriage rates are low. And this is one of those empirical treatment which is there in the scientific field known as more of an empirical treatment. But well, that is a treatment without any side effects if you use it for 4 months. But then I see women who have been prescribed DHEA after DHEA by one doctor and the other, and they land up taking it for a year or two. Well, few of these women would develop androgenic effects. Androgenic means male-like effect, where they can have excess hair, a lot of acne, darkening of the skin, sweatiness, all that thing could be there. Otherwise, if you take it for a short period of time, believe me, the side effect profile is pretty low. So DHEA will help you improve on the quantity or to maintain a certain quantity for a longer time. The second trick which I commonly use in my practice is coenzyme Q. Coenzyme Q is nothing but coenzyme Q. Coenzyme Q, if you remember in biology, biology tells us a cell has a nucleus, mitochondria, cytoplasm and a cell wall. The nucleus is a genetic structure. The mitochondria are the ones who synthesize ATP, which are the energy takers. So all the energy to do the cell metabolism is from mitochondria. And this coenzyme Q, it directly affects the mitochondria, improving them so that the cell functions better. So, giving a prolonged coenzyme Q treatment in my practice, I have realized that I get better pregnancy rates. My women respond better to my drug protocol, and pregnancy rates are high, and the miscarriage rate does come down. So, this is another prescription which I give in my practice. The last, obviously, is supplementing folic acid with vitamin B12, and I have not mentioned vitamin D, but vitamin D also, and that will also give a better initial groundwork. So, this is one of those background treatments which I give to every lady who is having a diminished ovarian reserve, and then I put forth on the front line the further therapies to achieve pregnancies. The further therapies could be simple HMG injections, and my favorite has been Menopur. Menopur or Gonalep are one of the best brands to be used, especially in women with poor ovarian reserve. Though a little expensive, but these brands can be used as a lower dose. So if we add lower dose, they will give a fantastic result. Cost effectiveness also will be there. The egg quality will be much better, and the pregnancy rates. And when I look back at my scientific data and all the studies which have been published in poor ovarian reserve, what I realized that most of the studies have been published with these two drugs, Menopur and Gonalep. If the whole of the world is using these drugs to achieve best pregnancy rates, why not us? So in my practice, I prefer using Gonalep and Menopur to my patients who are having low ovarian reserve. And what I should remember and tell you when we are using treatments other than IVF for somebody who has been diminished ovarian reserve, please don't get disheartened if you don't achieve a pregnancy at one time. Have some patience. Keep your cool. Keep your emotional stability, so that you should be attempting smaller treatments multiple times, maybe 3 times, 4 times to get that success. So using good drug in a low dose makes a difference here because you're going to use it multiple times. So side effect profile is very low with Menopur and Gonalep, almost nil side effects, I would say. I have not experienced any side effects with these two drugs. The pregnancy rates keep high. Well, there would be a chunk of now women who are having low ovarian reserve who have not responded to my background treatment and my initial treatment of using gonadotropin in low doses. And that's where I start telling them I'm thinking about going for an in vitro fertilization, IVF or EC. And then I divide these patients into different subgroups. And the scientific literature today tells us to classify the patient according to Posidon groups. Posidon group 1, 2, 3, 4. I don't want to confuse you because that's too much of scientific jargon I will be using, and you are lay people and general practitioners. It will be difficult to understand that scientific jargon. So I'll keep it away when I teach my gynecologists or when I'm taking as a foreign faculty for many students there. But I would like to tell you simplistically This is the way I would tell. Low ovarian reserve, when will we do IVF next? So I would put one group of patients who have taken those treatments, not successful. Women having an AMH more than 1, but less than 1.8. I find it less than 1.8 is my low reserve. And FSH level less than 8. So you have an AMH low, FSH still holding on to normal. And these patients, typically, we will do a standard protocol. This is what I call a standard protocol. We will be starting the development of egg from day 2 of the menses. We will give it for a period of about 10 to 12 days. A lot of the women require only 10 days of stimulation only. After first 5 days of injections, next 5 to 6 days will be 2 injections, antagonist and menopause together. Believe me, taking 10 to 12 days injections is pretty simple. You can do injections yourself. Like we can tell your husband how to give the injections. All ready-made syringes are available. It's like taking insulin. You can take it in the thigh and store it in your day-to-day refrigerator. And harmless injections, no side effects, especially menopause and gonadal are pretty safe. At the end of 10-11 days, we will have nice eggs which are formed in ovary. And once those eggs are beyond 17 millimeter, we'll be giving a dual trigger. A dual trigger with HCG and GnRH agonist will be given to you. And after 36 hours from the trigger, we'll take the eggs out. This is a standard protocol of IVF for all my patients. Many of my patients with poor ovarian reserve can go for fresh embryo transfer. Like we develop the embryo, by day 5 we have a blastocyst and put it back. Or you could have the cleavage stage and put it back. A few of the women will go for freezing of those embryos, and that's something which is very scientific. And I would not explain you now on this video about who goes for freezing or not. We can definitely, when one-to-one consultation is there, it is a very individualized decision making which is done, and I would guide you which is best suits for you to achieve your faster pregnancies. But then I have another group of women who are ovarian reserve is lower than what I mentioned in the earlier case. Herein, your AMH could be less than 0.8, FSH could be between 8 and 12, or you could have an AMH even less than 0.5 and FSH could be beyond 12, and this is the worst group I would say. AMH is less than 0.5 and FSH beyond 12. Or your antral follicle count is less than 3, just every time you do a sonography, just 1 and 2 eggs are seen. And ovaries also become very small. Ovarian diameters is 1 centimeter, 1.5 centimeter, very small. But these are the women who really require a very special treatment. Commonly, a lot of doctors and gynecologists would advise them to go for an egg donation study. But I think I would leave the choice to the patient. I would give a very informed decision making, and patient and the couple's participation in decision making is very valued in my practice. I would explain them the true pros and cons of the whole IVF procedure, what is going to be the cost, what is the cost effectiveness, what is the truthful success rate. The success rate is also low in this case. And then after this complete information, the couple in discussion with me will take a decision what kind of therapy is needed. And the standard treatment is something which I don't use for this, because standard treatment makes the whole treatment a bit expensive. It increases the cost. But anyway, if the eggs number in the ovary is less than 3, how am I going to get 6 eggs out of it? Not possible. So, I will give a minimal stimulation. So, I use less number of drugs. Maybe use a tablet like Fertility with drugs like gonadal and menopause. So, just 3 or 4 injections or 5 injections of gonadal and menopause and a drug and Fertility. What is the difference here? The most important advantage is the less on the cost. The cost just comes down to 50,000-60,000 rupees. And then you go for a pickup. You will get about 1-2 eggs, you form an embryo, and if you feel the whole thing is conducive enough, put the embryo back and achieve pregnancy. So this is called minimal stimulation. And this is also called clomiphene-based stimulation protocols, or sometimes I use double stimulation, back-to-back stimulation. What happens is, in a few poor ovarian reserve, when I use minimal stimulation, I'll end up getting just 1 embryo. And I know that when I put 1 embryo, my chance of pregnancy is going to be just 10 to 15%. And if the age of the lady is beyond 36 years, even that pregnancy rate is not there. So, what I prefer is to do double stimulation, or some people also call it duo stim. So, I will go with 1 more course of stimulation. I'll make 1 embryo from the first stimulation, reserve, vitrify. I'll make 1 more embryo of another stimulation, and again reserve and vitrify. So, now I have 2 embryos, and I will pull them up. That's called embryo pulling. And collectively, I will put 2 embryos inside, and probably my pregnancy rates will go up. And sometimes getting a blastocyst is a problem. In 1 cycle, I may not get blastocyst. Or 3 cycles, I may just end up getting 1 blastocyst. Well, now, these are the various ways of minimal stimulation which allows that couple who is desperately seeking their own genetic material. They want to say, the lady is saying, well, I have to use my own egg. I don't want to take a donor egg. I want to use my own egg. And these are the ways we will help them out to achieve their own pregnancies. It's such a blessing from God when you get your own pregnancy from these very minimal eggs remaining there because of such scientific backup and scientific execution of IVF programs in practice. The advantage of minimal stimulation, as I told you, is it's a cost-effective option and allows you to have a self-egg pregnancy. The disadvantage is it does keep a little low success rate. Embryo pooling may be necessary. So, you may have to do 2 cycles together and so many days of injection. But again, injections are only for 5 days. So, taking 2 sets of 5-day injection over a period of 1 month should be okay with many of the women. Now comes the last part of it. Some women are worse than all these categories and they require what is called an egg donation, wherein the egg reserve is so bad that all our attempts earlier to develop your own eggs have failed. Or you have attempted your own egg development with 1 or 2 of IVF cycles and unfortunately you could not get an egg, you could not get an embryo, or you are not being successful in achieving pregnancy. In scenarios like this, sometimes we request the couple to go for a donor egg program. So these are the women who probably maintain a high FSH. So suppose your report is saying an FSH level beyond 14, your antral follicle count is just 1 and 2 and AMH is less than 0.3. I would request you don't experiment much. Do think of egg donation to get a faster pregnancy. Now, this graph which I am showing here, now it is just telling you how an egg donation can make a difference. So let's say, go to this lady who is having 40 years of age on this graph. If you see her pregnancy rate is going to be less than 20%. But see with donor egg what is happening. With donor egg, she is having a pregnancy rate is near 50%. Because the donor egg uses a good number, gives us a good quality of an egg, and her only factor was bad number of eggs and bad quality at the age of 40. And at the age of 40, having genetically defective baby, having an abortion is very high. Now that incidence goes down because you are using a donor egg. So donor egg is also a huge blessing for somebody who desires a faster pregnancy, who is having a low ovarian reserve, and they say, well, we are middle class people, or we cannot go for IVF after IVF. You would tell us something which will be highly successful in our limited resources, and I am willing to accept donor egg program after knowing all the intricacies and details of this donor egg program. Well, you're welcome. You should go for donor egg program because I'm not treating a disease here, I'm treating a desire. And once we discuss it openly, advantages, disadvantages, cost effectiveness, time frame, all the timelines and everything, probably it's a very easy way for the patient to participate in this decision making and go ahead and take that decision up. Well, thank you so much. I hope I'm been very clear about my protocols of managing a poor ovarian reserve patient step by step, and especially how we take care of their IVF. I'm sure you would like to know more, and please put your messages and comments onto Sunanda Fertility Clinic Facebook page. I'm giving you a very attractive phone number there, 75176444444. You can WhatsApp your message here, or you can just call upon this to take an appointment, or just email me whatever your queries are. Thank you so much for